Good morning. I have to remind you, you can admit your questions at the end of the session using your app. And then we'll have a discussion at the end of the three conferences. The first talk is Remote Monitoring of Peritoneal Dialysis Patients, a Time-Tested Approach, presented by Dr. Shivanand Karopadi from the Virinchi Hospital. He's a pioneer in the field of peritoneal dialysis internationally, and cadaveric kidney transplantation is well known in the area of acute kidney injury. Dr. Karopadi. Please come up.
Thank you. I think you got introduced with a tongue twister. Actually, I'm a simple Nayak. So that's my family, my forefathers, Karopadi and all those things, but that's not a problem. I'm here to talk about a software which we have developed. I think remote monitoring of home dialysis is going to be one of the most important developments. We expect to change the what you call the entire scenario of peritoneal dialysis, especially, and home hemodialysis also worldwide. I begin by thanking Peter and his team for putting up a great show and a fantastic facility. Thank you, Peter. So remote monitoring of peritoneal dialysis, a time-tested approach, specifically because probably we were the first ones to realize the need for such a approach to home dialysis. We started way back in somewhere around 2005, working. It's been a passion ever since, and now I would confidently say that this is one of the best. This is the best standalone software you can see to monitor a patient at home. I have no conflicts of interest to disclose. Now coming to certain basics, nomenclature for telemedicine. Since there's no pointer, I look at this left side and I'll describe them to you quickly. Telemedicine and telehealth are similar, using high-speed, high-fidelity internet connectivity for whatever purposes. Remote monitoring will be using telemedicine or telehealth for monitoring their health status and getting health information from them. mHealth, the mobile health, is using devices which can help us do this. And now the next two, asynchronous and synchronous. Asynchronous is sending information to the healthcare provider where it will be stored and you won't get it in real time, access to that. But as synchronous, or something like what ours is very little, almost real time. Real time information is transmitted between the patient and the healthcare provider. And I think distance site and originating site, I'll come to that in a moment, but this has assumed very important significance in the United States because of the recent, I think from January 2019, the laws of, the reimbursement policies have been changed depending on where the originating site and where the doctor is and where the patient is. I'll come to that soon. So the requirements for an ideal remote monitoring system and APD is the ability to allow flexibility, two-way communication, simple with intuitive alarms, modifiable, customizable, should not be intrusive, and should monitor both. I'm concentrating only on PD, so it should be monitoring both for manual PD and APD. I think all of you know about the HIPAA and the HITECH Act. HIPAA came in 1996. The Title 2 of 5 of HIPAA establishes policies and procedures for maintaining the privacy, which is very important. The information of the patient breach can be pretty disastrous. You can get jail sentences for that. And HITECH came later. According to the Department of Health and Human Services, It outlines national standards for electronic protected health information, what we call EPHI, that is created, received, used, or maintained by the covered entity. So because it's a SIM card that is used, it can be hacked. So, and there are certain regulations you need to follow to make sure that your software or your platform for the protected information, healthcare protected information is secure. So this is exactly what I was saying. This applies to all forms of PHI, which include paper, oral, or electronic. Furthermore, they say only the minimum health information necessary to conduct business is to be used or shared. Then came the HITECH Act. Many thought it was a replacement for HIPAA. No, it wasn't. It came in 2009. Actually, it makes it more streamlined and is complementary to HIPAA. And the idea was to set a meaningful use of interoperable electronic health record adoption in the healthcare system as a critical national goal with incentivized EHR adoption, which is in Canada, you have equivalent PIPEDA. This was started in though it was started in 2000. In 2002, the PIPEDA Act was expanded to include healthcare sector. So every country, in India, we have what is called, I'm from India, by the way, we call it the DISHA, which means Direction, Digital Information Healthcare Security Act. So we have this, so much so that you have now an entire industry with HIPAA accessories. You can see them there, blackout screens when viewed from the side, from prying eyes, you cannot read what is on the screen. Whereas for the person seated in front of the computer screen, you can have a crystal clear screen. You have shredders, toolkits, chart holders, a remote data wiping system. You can see the figure before VIPPS, the one there. From a remote area, you can wipe up the healthcare information that is there if you are worried that there might be a breach. So all sorts of things. It's an entire industry now. One point I would like to make clear is that probably the smartphone is not a good idea to have remote monitoring. The device cannot be carried on person. Ideal device should not be carried by a person 24/7 because there are risk of theft and of using unsecure Wi-Fi. I think you know, you send in your passwords and your banking information through the phone, and you go to a restaurant and you're just going to the toilet, and when you come back, your phone is not there. So that's a very easy and disposable item, very, very attractive for the thieves or whatever, because they can dispose it, and it's quick money. So that is one reason. Close to none have antivirus in their phones. Every device, we ideally need a device which the patient doesn't move much from the home where the patient is undergoing the treatment. Some might say that the patient can take the device wherever they go, and that would be a good idea. No, it's a bad idea. It should be probably restricted to the home where the patient is undergoing treatment. Screen size is another area where for basic data, a small screen might be okay, but for for treatment purposes, imagery, you probably should have a much bigger screen. Something like, so mobile phones are particularly, as I said, vulnerable to threat. A recent survey of 600 US hospital executives, physician organizations, health insurers, and life science companies found that theft accounted for 66% of reported data breaches over the past 2 years. They're typically light and I know fashionable to put it in your back pocket and very easy for theft. Many companies, hospitals give their phone. I think the incidence of Hillary Clinton comes to mind. She used her own phone for emails, which was a problem. It was not an employer-issued phone. So a personal phone definitely will not be as safe. I mean, a personal phone will not be as safe as an employer-issued phone. And an estimated 81% of 2,041 physicians reviewed were using their personal phone, whether it's a BlackBerry, Android, or iPhone, to access EPHI. which is not a good idea at all. Phones don't have authentication, much of it, don't have much encryption, and the Wi-Fi connection, they use whatever hotspot you get. Whenever you get a free Wi-Fi, you tend to log on to it. Bad ideas, so it's all there summarized. Right side is just a humorous, I mean, you can make deadly, very embarrassing mistakes when you're sending a phone because of the small keyboard and the predictive languages. You can have a very embarrassing conversation going both ways because of smartphones, and they're limited in storage capacities. So I would strongly recommend that what you call the remote monitoring should be done on probably a laptop or a big monitor, or minimum is the size should be of a tablet or Apple device, the iPad. Even my iPad is okay. Between the two, if you ask me to choose, the Android has an advantage that it's cheaper, whereas the iPhone is slightly more expensive. But the iPads are very flexible and geared towards health apps, and they're easy to comply with HIPAA and high tech. Now, a little bit about the share source. Some of you might have been using it. Basically, this was developed by Baxter for their automated cycle devices, and it was looking at the compliance of the patient. Compliance as in whether they were really doing the exchanges, and the other thing was whether there was inflow or outflow problems. Basically, that's the only thing it was looking at. So it's a two-way cloud-based technology, and you can see the red ones are where the patient skipped the exchanges, and then you can see the classical graph, probably the middle one, and in the three, you can see that there was poor outflow. So this is actually the only data that comes from this share source. So I basically think, how can you predict peritonitis? How can you predict that there's an impending peritonitis? These are being claimed now by share source. It really doesn't make much meaning to me that you could predict that based on just the compliance and the outflow-inflow issues. It's like, reminds me of the six blind men touching the elephant and getting their own impression. So I don't think it's a great idea. Share source is not going to be really that helpful in monitoring the patient. Way back, so I'm coming to our experience. Way back somewhere in the early 2000, I had a patient about 1,000 miles away from my PD unit. I'm in the south of India, and this patient was in the north of India. He sent me an attachment of his exit side and sent me, and that's when it suddenly struck me. That's the map of India, the yellow. So we started using attachments of various pictures, and then started from there growing into developing one of our first basic softwares which allowed us to monitor the patient. We published that in the PDI, Use of Peritoneal Dialysis Remote Monitoring System. This was version number 1, I would call it. And then subsequently, we have now version number 3. We're on to version number 4, so now we are using tablets and iPad. Many iPads can be used. We published extensively. The Harvard Business Review shadowed me, and they said, yes, this is something which is amazing. And they really found that it could be very relevant to the big countries, developed countries, where access to healthcare and the need to come and see the doctor is going to cost them a lot. And we've done a lot of studies, including reduced hospitalization and without taking purchasing power parity, which is it's 4 times like the Indian rupee and the dollar purchasing parity, power parity is 1:4 actually. So, for example, if $1 is 60 rupees, it's actually $1 is only 15 rupees. So, without even considering that, patients were saving something to the extent of tens of thousands of dollars by using the software. This is the point I was talking of. Susie Liu from Washington University, This just came up in the AJKD. She wrote about, I think one major jigsaw puzzle in the jigsaw puzzle of operationalizing is the software. But then the opening up of the reimbursement for the physician is now possible. First 3 months after you start PD, you don't get reimbursement. And then every 3 months, you're supposed to have monthly interaction with the patient. One should compulsorily happen in the hospital situation. The other two can happen wherever the patient is or wherever the doctor is, and it will be charged like a face-to-face. So 2 out of 3 in the 3 months, after the first 3 months of patient stabilization is reimbursed totally. So this is only the beginning. I would expect that ultimately this will become the norm, and you will get reimbursed for each one of your interaction. This is the basic schemata of our device. The device at the center, the patient, you can see at the left, got access to all this. Through all this, I mean, it's just very simplistic, but the tablet application is interactive PD exchange process, checklist for increased compliance, audiovisual is very, very important, audiovisual and image capture, clinical information capture and review, inbuilt chat facility. If you see when you do Skype, you put off the audio so that only the audio, so that even when there is poor connectivity, you can interact with them. So we did the reverse. You put off the video in the Skype and keep only the audio, so that in spite of poor connectivity, you can discuss some issue. Here we have replaced the audio with the chat facility, but the video part is retained, enhanced security, scheduling, and supporting both the APD and the manual PD. So the small one is for doctors on the go for the PD nurse and for the patient, and the patient can access only their information, whereas the one in the PD unit, the web module, is a regular computer or a laptop where you can access every information of every patient. So the features of the web-based, the one in the PD unit we have is instant image and audio-visual access, chat, live communication with synchronous. So you get to know patient history, patient investigation progress, scheduling of patients, PD nurses roster, HIPAA compliant, facilitates research. We can do research because we're putting in that information of the bugs that they had, the infections they had, and in-depth information. So this is how the screen looks on an iPad. There is a 13-step monitoring the patient on PD right from beginning, surroundings, then the hand washing techniques. This is not compulsory, but if you are feeling that the patient is not doing the treatment properly, you can do that. It's a 13-step procedure. You can see the concentration, whether the bag is having any leaks. You can see on the top the patient's demographics. That's the particular patient. He actually came online, and we had in the ISPD Madrid, that was six years back, we had a live demo. Patient was in Hyderabad, India, and on the screen you could see him, and he was interacting with the audience. It was amazing stuff. And subsequently, I wrote an invited editorial in the PD International about how we should take it forward. You can see here the web chatting between me and the patient. So here, image and audiovisual capturing, you can see that there is a scope for a camera, and then there's a scope for a video. Video clips are 45 seconds. The camera, basically we want one, I'll show you, one with the picture of the effluent bag, one with pedal edema, one of the exit site, and one for optional, whatever else you want. It's the same thing in the video. We have 45-second clips, which can be repetitive. They come and embed into the patient information within about half a minute. So it's almost synchronous. And then you can review. And then you can tell the patient through web chat, I want a little different, raise the catheter a little bit and show me the underside, this side of the exit side. So that's how it goes. So you have you have got a zoom there. You can actually have expanded impression of the exit side. And then you have the bag, which we have a background font, which we found and we have published with almost 100% sensitivity that if you can see 16 to 18 times Roman font through the bag, effluent bag, the effluent bag is like a lens. It's like a convex lens. And if you can see it clearly, then most likely there is no peritonitis. Then you can see the exit site. So this is how it looks. You can see that's a clear-cut case of peritonitis, and the patient has to come to the hospital. But you can see here, the last picture is a clear font visibility, so you know that the patient is fine. So this was one of the things that came up in NEFJC, those who use. We allow the patient to keep a stock of antibiotics at home. This is something very interesting. After finishing the 13-step procedure and the video image and all those, you can see here, they fill in it takes about 3 minutes to fill in the SF-36, the physical health and the mental health. You can see clearly here the patient started deteriorating a little bit, and then that's the time we catch them. And then we probably might send our PD nurse for a home visit. We find out what's wrong, and then we correct it, and then you start seeing that the SF-36 starts improving. This can be done by telemedicine, remote monitoring, and the patient can be anywhere on the face of the earth, even on the Atlantic yacht or probably on top of Mount Everest, as long as they have connectivity. You can schedule your nurses. One thing I wanted to tell you is you need one sister for 20 patients is the accepted norm. But one nurse can handle 100 patients using this software. And this is what is called PD rounds. You can see that green cake. That means all patients are doing well. And as you can see, logging in is like for a credit card or something like that. It's pretty secure. So you can see a patient has a problem there, and that is rectified. You can finish your PD rounds in about 20 minutes. We have a very busy unit, and those problems that can't be sorted out by the nurse is taken care of by us, and all your patients are fine. Then you have the web chat. This is the SF-36 questionnaire, and then you get the marks, and then you get the histogram saying how their mental health, the numbers are quite okay. This was the chatting that I think I showed you already. The cake has become green and the rounds are over. In fact, our software was included in the ISPD guidelines recommendation saying that this is an excellent way to take PD forward. So just to give you some, so basically somebody can be on the Atlantic and be doing PD, and you know about the story of Tony Ward. If he had a satellite phone, he could have connected, and he wouldn't have been like Santa Claus on 24th of December, stuck to the dialysis machine. So they would be free to do whatever they want, and they would be connected with us and 24/7. So that's the advantage of remote monitoring a patient on home dialysis. It aims at integrating all services necessary for PD, making them easily accessible to the patient, the primary caregiver. And the most important thing, I was at this particular place, I was part of the 0/25 initiative of the ISN and in the implementation committee. Sundarbans is in the northeast of India near Bangladesh. It's known for its the Bengal tiger. A patient has a home who doesn't have electricity. He has the solar. You can see the panel there where I'm standing over there, and he was connected to me through the software using his solar panel. And last couple of slides, the financial implication, as you can see, a 5-year budget impact analysis was performed using data from the 2007 annual data report of the US RDS. Scenarios were developed, and impact results were, if PD share of total dialysis were to decrease from the, at that time, current 8% to 5%, Medicare spending for dialysis would increase by an additional $400 million over a 5-year period. Alternatively, if PD share of total dialysis were to increase by just up to from 8 to 15%, Medicare could realize potential savings of more than $1 billion over 5 years. So I think telemedicine is one thing. There's a perceived feeling in the patient that they're away from the caregiver, and remote monitoring will definitely bring them closer to the hospital or the caregiver and give them a feeling that they're being monitored and taken care of 24/7. And that will definitely reduce the dropout definitely, because of better reduce hospitalization and better care, and the feeling that I'm taken care of would encourage more to take this treatment. This is only one of the ways, like we were talking yesterday of urgent start PD. That also can increase PD penetration. I think if it comes to about 25%, you're probably talking of saving $3-4 billion in every 5 years for peritoneal dialysis through remote monitoring and other means. So don't think telemedicine is like mumbo jumbo, Aladdin, and all those like magic. It is closer to us. It's just like this. I like this slide which says what the objects in the rear view mirror are closer than and larger than they appear, and that's true of telemedicine. It is going to come on to us, and we should be prepared and ready to implement it for the sake of the patient, for the sake of saving money, for the sake of saving our time, for the sake of, I heard that some nurses were complaining that their workload will increase, in fact, it will decrease. So for all these, and for better patient care, I think telemedicine remote monitoring is going to be here, and the earlier we accept it, the better. And it's time to think out of the box. And thanks for your time and listening to me. Thank you very much.